Thank you. Again, I'm just going to talk about what is neuroergonomics and just to give a brief details about some of the neurotechnologies or neuromodalities. It's not that you guys don't know. All of your physicians are in the elite health. And I'm going to talk a bit about, or rather, I focus more on functional near infrared spectroscopy. And I'll give some few examples and including a case study and conclusions. I just want to let you know that I'm not doing research in neuroergonomics now. So I left the field almost 10 years back. But I'm just going to give you some of the things which are happening in this field. Okay. Uh, just, father of the neuroergonomics, this is a very interesting field because we are trying to look at the study of the brain and behavior at work. Okay. It was initially proposed by Dr. Raja Parshuraman from George Mason University. Before that, he was at the Catholic University. And he was a human factors trained researcher. And it emerged at the very end of the 20th century with the aim to study the brain at work and in everyday life. Okay. And it's essentially a mix of neuroscience and ergonomics. So, as you know, neuroscience is the study of brain structure and function, whereas ergonomics is studying humans at work. So, it's an intersection of these two fields. Neuroergonomics is concerned both with the brain and with the humans at work, but more precisely with the dynamic interaction, human brains at work. As per Dr. Raja Parshuraman, to paraphrase the philosopher Mario Bunge, I think, uh, until recently, the period up to almost close to 1990s, the psychology and ergonomics has been brainless, whereas neuroscience has been mindless. So basically, neuroergonomics is a response to this disregard in terms of the field. So the background for the neuroergonomics is more of, again, it combines different fields, as I mentioned, especially the cognitive neuroscience and brain imaging, a lot of bioengineering aspects of it, genetics and computing science. Obviously, human factors and ergonomics is mixed into that, as a field to understand human performance in the real world. A lot of earlier work was done in functional neuroimaging and the BCI and the neurofeedback and neurostimulation. So you see a lot of research in this field and in combination with some of the physical work or cognitive work. Okay, if you look back again, the spectrum is wide. Yes, you have these highly controlled and restricted settings. You can understand the brain, but also now, if you look at wearables, it's been huge in terms of the field, which how it has grown. Majority of my research was in the lab. But there is quite a bit of research, in terms of the high fidelity simulators and the realistic settings. And obviously, you can take some of this technology into real settings, so real workplace. So again, a huge, exponential growth in the last 20 years or so. So the market for the neurotechnology, this is from Professor Brandroff from Drexel University, Biomedical Engineering. The market, as I said, until now, the research in neuroergonomics could only be conducted in highly controlled clinical labs using invasive procedures, but engineering advances now make this work possible in real-world settings with non-invasive wearable devices. The market, if you're looking at neurotechnology, which is defined as any technology that interfaces with the nervous system, is predicted to grow to almost 21 billion by 2026. So again, if you just type neuroergonomics, on PubMed, you see so many publications. To the extent that a few years back, a new journal, the Frontiers in Neuroergonomics was started. So the impact of neuroergonomics, again, I've been saying that, there was a huge growth. Again, you're trying to understand the brain structure and function within the context of human cognition and behavior across the work or, home or, uh, activities of daily living. Um, it investigates the neural foundations of perception and cognition, including seeing, hearing, intention, memory, decision making, and planning in relation to real world technologies. And of course, it also explores the neural basis for physical performance, including grasping, moving, and lifting objects in the workplace. Again, the brain interaction with the world through the body. And if you look at it, there's a very good paper from Dr. Ranjana Mehta and Dr. Raja Parshuraman. It's in the Frontiers in Human Neuroscience. If you look at, in terms of the temporal resolution versus spatial resolution, you see all these techniques, right? All these modalities, which are very, very, some of them are very expensive, some of them are very intrusive, if you want to, bring it to the real world. But there are so many neuro modalities you see in the field. And so again, you're utilizing neuroimaging techniques to understand the brain structures and the functions during work. Techniques majority fall into two categories. You have the direct indicators of neuronal activity. If you're trying to understand that, you have the EEG and ERPs. And also, if you're looking at metabolic indicators of neuronal activity, then you opt for functional magnetic resonance imaging, or PET, and also the functional near infrared spectroscopy. Okay. Again, essentially, if you look at all this, if you group all these neuromodalities, you can put it in the spatial versus temporal resolution. Because if you wanted to understand what's happening in the brain, but in the real world settings, definitely these X and Y axis are definitely very important. Yeah. Again, some are invasive, less practical to use on the worker, or even for our the lab studies as well, versus there are few less invasive and more practical. Okay, what I mean spatial resolution is that you have the smallest features of measurements that a scanner can detect, and is an important feature of the brain scanning techniques. Again, you're all in the field, health field, so you definitely know the importance of both, resolutions. So again, what temporal resolution means is that you're taking readings every millisecond, meaning it can record the brain activity in real time, as opposed to looking at a passive brain. Okay, that's a functional. We are looking at the functional aspect of it. So again, EEG, it represents summated electrical activity of neurons firing in response to motor or cognitive stimuli. We're recording on the scalp, and it offers high temporal resolution, of electromagnetic changes, and on the order of milliseconds. Whereas you're looking at the fMRI and PETs, they focus on cerebral blood flow in response to neuronal activity. They have a low temporal resolution, on the order of about 10 seconds, but offer high spatial resolution, 1 centimeter or better, and unlike the EEG and the ERPs. Okay. And again, going into the aspects of it, both in terms of temporal and spatial, the EEG-driven metrics, right, in evaluating brain function during naturalistic complex tasks, it's easy, to use EEG compared to some of the other techniques you see on the X and Y axis. But as you know, EEG detects the activity in the superficial regions of the brain. And so it doesn't give you enough depth in terms of what's happening in the brain during work. And whereas PET, it uses injected radioactive tracers to measure the blood flow in response to stimuli, which is, difficult to get uh, uh, applicable in the field. And fMRI techniques is similar to conventional MRI, but which which takes the pictures of the anatomy of the brain. But what you're doing is here the functional anatomy of the brain during some activity. So that's the fMRI in a nutshell. And so fMRI focuses on the contrast between oxygenated and the deoxygenated blood, the bold signals. And so again, if you're looking at fMRI, it's a high spatial resolution and a localization. There are a lot of studies look into integration of both fMRI and EEG. But again, it's definitely a very tough task if you're trying to look at a person who's lifting the in the worker who's doing some activities at work. To bring the whole technology into the real world can be a bit tricky. Um, Again, typically participants have to be in a supine position that may be in altered hemodynamic changes than seated or standing positions. I know there are MRIs which are, I think you can do standing as well, but still, again, if you are trying to bring it to the real world applications, it can be tricky with respect to the fMRI and PET, and also the need to examine brain activation patterns in complex tasks. Again, if you're looking at the naturalistic environments, which can be very tough with respect to these modalities. So this is where functional near infrared spectroscopy became huge, very popular. So a lot of universities are doing this work all over the world, especially in the US, Canada, and also Europe. And this one is actually from Netherlands. Very popular. I'm not, what do you call? I'm not a sales guy, but this is one of the very user-friendly devices which you can use. Uh, FNIRS has been used in a lot of neonatal research as well. So what you're looking at is when I'm talking near infrared spectroscopy, it's more of a wavelengths, between 780 nanometers versus 250 nanometers. But as you look at, the slide in the bottom, you are looking at the depth of the tissue. When the near infrared goes into the tissue, the depth of penetration is a lot uh, higher or deeper, I should say, compared to the ultraviolet or the visible light. Okay. And so again, what a majority of the research, or rather, I should say, majority of the FNRS focuses on, between the 780 or 700 to 800 nanometers. You have the oxygenated blood and the deoxygenated blood. Again, if you're looking at attenuation or absorption coefficients on the y-axis versus wavelength, you have a first window, which is called, between 700 to 800 nanometers. And the second window is beyond 1,000 nanometers. So where you are trying to identify the oxygenated versus deoxygenated blood, using this spectroscopy. So what you're doing, again, in simplistic terms, that pulse oximetry basically measures arterial saturation, right? But here in the near spectroscopy or the functional near infrared spectroscopy, you're looking at the venous side of it. Okay, so that's a fundamental difference between a pulse oximetry versus a near infrared spectroscopy. You're looking at the arterial side of it, but here you're trying to venous side of it. That means you have this contaminated signals as well. Right. So again, just to, emphasizing the absorption spectra, you have, sorry if I can go back here, you have, oxygenated blood in terms of HSB, and you have the I should say deoxygenated one, versus HbO2, oxygenated hemoglobin, you have cytochrome oxidase, you have melanin. All this, if you're looking at a spectrum, what you see is typically the wavelength versus, these profile. Again, majority of the research is if you want to get a better understanding of what is happening in the brain. Typically, we call medical spectral window. Why it is basically it's you have less absorbency, less scattering, you have high depth penetration in the tissue in that region. Typically at 760 nanometers, you have the deoxygenated hemoglobin. It absorbs more light. Whereas at 850 nanometers, the oxygenated side absorbs more light. So as hemoglobin is oxygenated, you see the difference between the absorption spectra. So again, if the absorption coefficient of the oxygenated one is known, then what you're trying to understand is the change in these concentrations. So that's typically two wavelengths, but you can also apply more wavelengths in terms of understanding what is happening in the brain or in the tissue. Okay. So typically, the red is the oxygenated signal you see on the spectrum. Or if when you're using this technology, the blue is the deoxygenated signal. Okay. Uh, in simplistic terms, what is happening is incident light. You have a source and you have the detector. The light goes into the tissue. Typically, they call it as a banana shape. Once the light goes into the tissue before it reaches the detector, you have this scalp, you have the skull, you have the cerebrospinal fluid, and you have the cortex. So that depends of there are a lot of technologies or the mod which are the lot of manufacturers use different source detector separation, but typically 3 to 4 centimeters depth is where you see a good amount of uh, uh, you know the absorption in terms of what is happening in the brain. So it uses reflectance phenomena. What I'm trying to say is that light, as you have three essential properties. You have reflectance, you have scattering, and you have absorption. So whatever the light is being reflected is being analyzed through this technology. Okay. Sorry, I should say. So basically, the amount of light recovered from this particular tissue depends on the intensity of the light on the tissue. You have the physical separation between the source and detector, and the amount of the degree of light scattered by the tissue and the tissue absorbency. Basically, it uses modified Beer's law in terms of the calculations or algorithm. So again, you get the responses in terms of oxygenated and the deoxygenated hemoglobin. Yeah. So again, you have different. I just gave this a snapshot of what typically how it works, but you see there are a lot of sources, a lot of detectors. So it depends on the complexity or the technology. Hitachi uses, I mean, I think more than 50, I believe. So the arrival was in 1990s. It was demonstrated that the functional activation of the human cerebral cortex could be explored by near-infrared spectroscopy. So there are a lot of studies published in the proceedings of PNAS, yeah, I should say, National Academy of Sciences, and a lot of special issues with respect to that as well. But typically those recordings, when it started, it was performed using single site. You have single channel, one source, one detector. But as the technology evolved, you see a huge. That's why in the very beginning I said, the child wearing a cap. So you have almost an EEG, system, but with near infrared spectroscopy approach. So again, what you're doing is measuring oxygenation and hemodynamics changes in the brain to functional activation in tasks. Okay. And then, now people, I mean, I'm yet to see people only using one channel with respect to near-infrared spectroscopy. People use multi-channels. Again, what you're doing is you're mapping the oxygenated and deoxygenated components of hemoglobin. Again, you don't, the technology has evolved so much that, you can carry in your backpack yes, during, if you wanted to understand what's happening in the, oxygenation in the brain, during running, walking, you name it, you can use this technology. Okay. So again, the FNIRS or the near-infrared imaging detects simultaneous changes in the optical properties of the human cortex from multiple measurement sites, and it displays the results in the form of a map or an image over a specific area which you study. So as I said, this is the Hitachi one, which is 52 channels. You're looking at oxygenated and deoxygenated channels here. Sorry, the responses during an activity, and so now you can you can do in combination with other. So that's why you see this bold signal as well. So you can, use both, FNIRS versus fMRI. And you see in this right side, this is a lab study, but still a pretty good study in terms of the driving simulator. You're looking at EEG, EOG, you name it. There are people have been using multi modalities and multi channels with respect to a functional activity. And again, this is the one which you can use multi, I should say, subjects, more than one subject at a time to understand the brain. Okay. Another example, a good friend, Professor Ayaz from Drexel University, he has been doing a lot of work, and especially the Drexel group has been doing some tremendous work in this field. So, on the right side, again, it's a lab one, but also you can carry to the outside world, with the wearables, with respect to the spectroscopy or the FNR sensors. A lot of studies looking into cognitive workload, the mental workload, and the fighter pilots as well. So there are so many applications. Again, not only in the lab settings, but also in the real world, you can take this particular technologies. So that's why it's been so popular compared to other neuromodalities, which I kind of give, in the beginning. All right. Yes, of course, people have been using it with respect to, yes, if you use a exoskeleton and you're doing some lifting activities, what is happening to your brain? Yes, the physical work, but how does it affect, with respect to, this is from Ohio State University and also Texas A&M. It's a collaborative effort, but what they're looking at is while wearing exoskeleton, what is happening to the brain versus the muscles. Again, wearing an exoskeleton imposes greater neurocognitive and motor adaptation efforts by engaging action, monitoring and error processing the brain networks. So there is a huge difference in terms of the biomechanical responses for the new cognitive responses. But what it says is that, where its biomechanical responses to increased cognitive demand may offset the mechanical advantage which you get from the exoskeletons. So there are a few more studies which came recently, but again, you can use um, the functional neural spectroscopy with different modalities and different activities as well. Here they're using EMG, surface EMG, in addition to the FNIRS. Yeah. This one is maybe close to your heart in terms of majority, as you know, physicians. So what they're looking at is the motor skills with optical neuroimaging in expert versus novice surgeons. It was published. This is an article published in Science in 2018. What again they're looking at is you have your performance scores. This is laparoscopic surgeons, and you're definitely there's a huge difference between the novice versus experts. But what is happening in the brain during during your surgery with respect to novice versus experts and also unskilled versus skilled trainees. So what you're looking at is the prefrontal cortex. As you know, it's associated with the decision making and motor strategy developments. So the PFC activation decreases as motor skill proficiency increases, as observed in the surgical experts versus novice. And higher executive functions, such as fine motor skill control, correlate with increased activation in the brain, and as expected in the surgical experts. And it confirms activation changes in the prefrontal and primary motor and SMA as motor skill proficiency improves. Again, they have seen significant changes with respect to novice versus experts and also unskilled versus skilled. And again, you can, bottom line is that, you can use FNIRs in terms of assessing any physical or, mental workload. So the strengths are definitely it's easy to use modality compared to other ones, but interpretations definitely need a good amount of experience in terms of what does the data say, the famous saying, drip data rich, information poor, it is always applies here as well. And yes, you can use it at the bedside. You can also use it in the workplace. It's non-invasive. It's portable. It's a majority which are now, portable and real. What you're doing is real-time measurements. Some of the measurements you can do for 8 hours and more. And you can, if you wanted to understand the heterogeneity of the different tissues during certain activity, you can do that as well. And also you can combine with other modalities, what you've seen, fMRI, EEG, EMG, you name it. But, definitely you have that opportunity with FNIRS. It's portable. The reason I put the relatively less expensive is that, it is definitely a bit expensive, but I mean, way cheaper than fMRI or fMRI and other techniques which I've seen. So again, if you're trying to understand the physiology of brain during work, definitely the FNIRS is way, way ahead compared to a lot of other neuromodalities. Okay. And huge, as I said, the high temporal resolution, that is the beauty of this particular field or the particular technology. And when I was a PhD student, I used only a single channel and a very very basic one. But if when I go to conferences, when I see that the technology has improved way way, almost um, almost 6 or 7 times in terms of um, the amount of information which you can get compared to 2 decades or 3 decades ago. So this is an example. I worked at Liberty Mutual Research Institute for Safety before I became a practitioner. But this was my last study. What I'm the guinea pig there, and what we were looking at is what is happening in your brain, in addition to your systemic responses. The oxygen responses, but during a lifting task. What the study is between. A comparison between a non-obese versus obese participants. We only studied the male subjects. So what you're doing, what the goal was to evaluate the role of obesity on whole body and cerebral hemodynamic responses. We published there is one which in EJAP, European Journal of Applied Physiology, and the other one was PLOS. Again, this was my last study, rather last lab-based study which I've done. And again, it's not that you guys don't know the influence of obesity. With increasing BMI, the neck and shoulder workers' comp claims have increased. So that and workers with the shoulder pain were twice as likely to have a BMI, greater than 29 kilograms per meter square. And back injuries led to workers' compensation claims were more common with higher the BMI, the higher the claims with respect to back. There are some studies which show that the increase in musculoskeletal injuries, particularly due to lifting and overexertion. The classic paper from Dr. Robert Gussel in 2010, which talks about that. And also during lifting load, an increase in percent maximum contraction and delayed muscle activation is also evident. So obviously with obesity, the balance recovery also impairs with weaker ankle muscle strength as a potential reason for that balance stability. Okay. Again, if you're looking at obesity and workers' comp, obesity versus workers' comp data, you see that, the lost work days definitely has increased. Same thing with the medical claims and also indemnity claims. So although it's, 2007 study, still a pretty good study in terms of the lay of the land, to speak. So what's happening at the cellular level? Again, we are looking at literature with respect to, the obese versus non-obese. Typically, when you're doing a physical activity, oxygenation increases to accommodate the increased demand, during submaximal work. However, at high intensities, or you're almost getting into the fatigue level, what is happening? But there are some studies which show that drop in blood flow is observed in the untrained participants, untrained in terms of the athletic, in the athletes. And so, excuse me, the question was that that vascular drop you see, or the drop in blood flow you see in the untrained participant, does that happen to the obese as well during the submaximal versus maximal work? That was our basically a goal. So the hypothesis was that yes, obesity will adversely affect systemic responses, and also they exhibit decreased central responses as measured by cerebral hemodynamics and the task performance. That was our goal, or rather hypothesis. The subjects, if you look at the population, the age group was almost the same. Definitely the heights are also same, but the mass, definitely you see the huge difference between obese versus non-obese. And even you see the skin folds, if you see that there's a difference, and circumferences, you name it. So that's a classic one. The course, what we did was we also looked at their fitness in terms of submaximal work. And then you have a graded lifting exercise. This was this particular one on the right side. You see the subject trying to lift a certain load. This particular lab is where this is Liberty Mutual lab where I worked. The baggage claim, you talk about 51 pounds. This particular one came from the research from here. Okay. The psychophysics, or the NIOSH lifting equation we talk about in terms of if you are an occupational physician or a nurse, or you look into the data, people use NIOSH lifting equation. That magic number came from this basically a lab, in the sense that the psychophysical data which was being used in the NIOSH lifting equation. So basically, this is the lab, which is a lab. The uniqueness of this particular apparatus is that as soon as you put the load, it senses, and so it gives you both so you can set it up at a different heights from the floor level to the shoulder height, and as soon as you put the load, it completely lowers it, and then you put the load, and so you can do both lifting and lowering. A lot of lab studies, they do lift and lower, but here you can do lifting alone versus lowering alone tasks. Again, every 2 minutes you're adding 5 kilograms, and basically the participants stopped at a predetermined lift criteria with respect to AC. We used American College of Sports Medicine guidelines in terms of when to stop the exercise. Okay. So the lifting again is until volitional exhaustion. You see definitely the difference between the load lifted between obese and non-obese. You have the lifting duration also is different between obese and non-obese. Obviously, the oxygen uptake, you see a difference between obese and non. There is a whole body oxygen uptake I'm talking about. If you're putting these, or rather, if you're normalizing with respect to body weight, you see the difference between obese and non-obese as well. If with respect to the load lifted as well, you see the difference between non-obese and obese. That's nothing new in this, in particular, in terms of the whole body responses. But the uniqueness in our study was we are looking at oxygenation in the left and right regions of the brain. You see definitely the difference, especially during the last effort of the 80 to 100% of effort. So I'm just going to talk briefly about that. Lifting trial versus versus the differences in these hemodynamic responses. So what you're seeing what it says is, but at low to moderate workloads, when you are doing lifting, definitely cerebral blood flow increases. You can detect that through the increase in oxygenation blood volume. It's mediated by increase in neuronal activity. As we are putting 5 kilograms every 2 minutes, you see that, yes, you need more oxygen, and you see that classic, an increase in the brain. So again, there is an increase in cerebral blood flow as well due to greater role of increase in cardiac output. You see that, indirectly, we did not measure the blood flow velocity, but there are enough studies which show that they are correlated. But that particular increase is not due to changes in the partial pressures of end-tidal carbon dioxide. So definitely the ventilation increased, but you see the end-tidal carbon dioxide. There is a bit of a decrease between 80% to 100% effort. Okay. However, at higher workloads, the changes you see, definitely has a physiological significance. See the drop, in oxygenation, and in the obese versus non-obese. So since what it says is that the if you're looking at the end-tidal carbon dioxide and the blood flow velocity decrease due to hyperventilation, because at that time you're almost getting exhausted, so it's you're almost in the final stages of giving up. You see definitely increase in, there is a blood, a decrease in oxygenation, but you see a huge disparity between obese and non-obese. So at the time when we were doing that, there are not many studies why there's such a difference. But there was a study from Canada, Patrick Neary looked at, the exercise with respect to chronic fatigue syndrome versus non-chronic fatigue syndrome participants. What it says is that the participants with CFS exhibited reduced blood flow throughout the graded exercise. Thus, reduced blood flow to the brain may alter neuronal function and the perception of effort. And for those with CFS, there is an impaired effort sensation from the reduced neural drive. That might result in the lower exercise tolerance. Yes, obesity might have a similar impact in the cerebral function as well. But again, we did not, at least, at the time we thought, that may be due to definitely, the decrease in blood flow at the maximal effort. Okay. So it's almost similar to the chronic fatigue syndrome patients. So based on our findings, the conclusions were that obesity impairs cardiorespiratory responses and also cerebral oxygenation, which may contribute to the reduced exercise capacity as observed in the obesity group, whereas the decrease in the cerebral oxygenation blood volume at the near or a maximal workload imply that yes, there might be a reduced cortical oxygenation that might play a major role in terms of terminating the lifting exercise in the obese group as compared to the non-obese. So I'm almost coming to the final few slides, but yes, you can use this neurotechnology. As I said, it's growing leaps and bounds. But can we apply into the workers aspect of it? Especially my focus is always on the worker side. So yes, yes, it has a dual use concern. That is, it can benefit or harm workers with a significant potential for misuse. What it says is that, yes, it can help diagnose brain-related conditions or, activities, but it can also lead to workplace discrimination, or it might be an insurance bias as well. It might have that. Behavior monitoring, employers, they could track workers' cognitive responses because, if it can be used as a wearable, this is a huge issue, as you know, where people have been using wearable sensors. Are you policing the worker? That's been a huge problem. So this can, definitely very intrusive in terms of, what you're trying to understand, whether the worker is, slacking off versus, you're looking at the productivity. Definitely ethical implications, it's still a huge issue with respect to this particular field, especially if you're trying to bring it to the workplace. Definitely the inclusive dialogue is needed. That means, you have to involve all the stakeholders in terms of protecting the workers' rights, because, end of the day, the privacy and the guardrails are very important. So, and I can't stress that enough, in terms of bringing it doesn't matter. The classic example is AI, right? It is basically, being used in the workplace, and that's been a huge issue in terms of the data privacy. So again, going into ethical questions in the workplace. Uh, you have the global impact, definitely, as I said, it has been far-reaching implications. But it definitely has the other spectrum. That is, you have the inequality or the loss of autonomy, and it can impact, uh, other aspects of, research as well. Ethical complexity, definitely, can I use it to monitor the brains of the workers? So there is a dialogue needs to be initiated. Um, Data protection uncertainty. Yes, brain activity data may fall outside the HIPAA guidelines as well. Um, this is more of, if you are using as a non-medical data, we need to have that as regulations in terms of uh, securing the data and also using the data. Uh, Definitely the consent and compliance comes into picture as well, because it still remains unclear whether employers can mandate, using these neuroergonomic devices. Hey, I can put a wearable sensor. I'm trying to understand your cognitive workload. I'm not sure how many people still, going to be okay with it. Uh, Definitely, you have the GINA issue as well. Last but not least, definitely ethical frameworks and the guardrails are still needed with respect to using this technology at workplace, both for use and misuse as well. So, and in summary, neuroergonomics has grown exponentially in the last decade. You can use different neuromodalities, as well as you can combine with non-neuromodalities to understand what's the human performance during both physical and mental activities. But definitely it has both ethical implications, and also the worker rights aspect of it. So, are we there yet? I'm still not sure in terms of the workplace, but in the controlled environment, and in terms of health, aspects of it. Say, for example, hey, I wanted to use this technology to, during walking or running. Yes, you can use it, but if you're trying to bring it to the workplace, it has a long way to go. So, thank you.